Kia ora koutou and welcome to Goodfellow podcasts. I'm Dr. Helen Carr, and today we are joined by Professor Ngaire Kerse to talk about multimorbidity and medication complexity in older adults. Professor Ngaire Kerse is a GP with a clinical fellowship in geriatric medicine. She is a professor in the Department of General Practice and Primary Healthcare and is the Joyce Cook Chair in Ageing Well at the University of Auckland. She is currently running a course called Multimorbidity and Complexity of Medicine's Use in Older People via the University of Auckland online. Thank you so much for being here, Ngaire.
Good morning. How are you, Helen?
I'm doing great, thank you. So I just thought we'd start by some definitions. How do you define multimorbidity and medication complexity in older people?
Okay, so multimorbidity, there's been a lot of research about multimorbidity now, and they started out by defining it as having two or more conditions. And of course, that's not very many actually. And so if you use that definition of two or more, by the time the average person is 75, there's probably 60% of the population who has multimorbidity and almost everybody who's in their 80s. So to my mind, that definition of multimorbidity is not that useful. My perspective, of course, is older people, but multimorbidity in middle age is also really, really important. So I like the definition of, 4 or 5 or more conditions for multimorbidity. Medication complexity, of course, to my mind, you can get in trouble with 2 medications if they're the wrong ones or if there's a bad combination. So thinking about medication complexity goes with the multimorbidity. And as you accrue conditions, you can accrue medications as well, of course. And so medication complexity, people talk about polypharmacy being 5 or more medications. But actually, from my mind, it's understanding what the medications are and what the combinations are that cause trouble. So I don't have a hard and fast definition of medication complexity. I think every GP or every prescriber knows that once you get some things for this and some things for that, and then you get a third thing, you have to think about what the medication complexity is.
Why are older people more vulnerable to medication complexity than younger adults? And what are some of the risk factors that make people more vulnerable?
I think we're all very well aware of the physiological changes associated with aging, and the main one, of course, is renal function, with a decrease in EFR and decrease in the ability of the kidneys to clear things. And so that's one of the main issues. The other thing about older people is that with the other conditions that they have, sometimes that causes a specific vulnerability to polypharmacy, for instance, cognition. Well, you've got to think about this without an ageist view, but the prevalence of dementia is low in the over 65 age group, but once you get to over 85, probably 1 in 5 people will have some significant cognitive impairment, remembering that dementia is a disease. And so once that is established, they're very vulnerable to polypharmacy because they get the pills mixed up, they don't take them, they take too many, they take their husbands or wives. And so renal function, other conditions that they have. And then there's the issues with dexterity and actually taking tablets. So don't forget that. Remembering complicated regimes, I can't even remember to take 3 antibiotics a day. So, when you've got 2 pills in the morning and 2 in the afternoon or 1 at night, and you have to think about those aids that go with taking medications that help, such as the blister pack. So there's quite a few reasons that older people are vulnerable. Some of them, what we learnt in medical school or nursing school or wherever you learnt about physiology, the pharmacokinetics and pharmacodynamics are different with aging. Receptor sensitivity is different, so older people are very susceptible to centrally acting medications. So the sleeping pills, which people love, hard to get off, they cause more trouble in advanced stage than certainly for younger people because of the receptor sensitivity.
Is age in itself a useful proxy for risk of complications related to multiple medication use?
Well, I want to say yes and no. The no is because there's still about a third to a quarter of people over 80 who aren't really on any medications that are harmful. So age has got nothing to do with them. It's the combination of conditions that make people vulnerable to the bad things that happen with polypharmacy. And so, of course, understanding that kidney function naturally declines and frailty is much more common in older age, they are significant risks.
What are the most common medications responsible for the most harm in this group?
Okay, so the literature says non-steroidal anti-inflammatories, and that's because of the bleeding risk. And of course, the bleeding risk goes up as you get to be over 80. And the second one is related to the other conditions that people have, and that's anticoagulants. So bleeding seems to be one of the big things to do with the most harm. The second sort of big group are psychotropic medications, as you can imagine, and they cause harm because of confusion, falls, stuff like that.
So what is your approach to a medication review in older people? How often, for example, do you like to arrange them, and what are you doing during that assessment?
Must be individualised, of course, because, of course, not everybody needs a medication review if they don't take very many medications, if they're well au fait with their medicines, if they understand their disease processes, etc., etc. But if somebody has diabetes, I think the medication review is really, really important every 6 months. If they have diabetes and congestive heart failure, that's one of the most dangerous combinations of conditions, then the medication should be top of mind every time you see them. And so medication review, what I try to do, time is the essence, but what I try to do is remember and talk to the person about why this medication was started, when it was started, whether that condition has resolved or got better or gotten away. So it's quite common that when people get treated with congestive heart failure, they get started on a lot of medicines and then they get diuresed and maybe their heart remodels or they get the underlying condition treated. And then over time, they potentially don't need as much of their cardiovascular medicine. So thinking about why it was there, whether the condition is still there or still a problem, and whether the dose could be adjusted, I think that's very important. And then I think about, so that's for each of the medicines or each of the conditions, whatever. And then I think about the overall person and what their needs are for prevention and whether there's things that are missing. Because, we forget that. Everybody's deprescribed, but actually we should be actively thinking about what people need. So, for instance, osteoporosis medications, bisphosphonates are underprescribed in older women, particularly older Pākehā women, because their risk of fracture is much higher. So, do they need that? Should I be thinking about that? That's gotten a lot easier over the years to prescribe. So each condition, that medication, is there anything that's missing? And then looking at it as a package and thinking what interacts with what and what's the absolute no-nos. And, when I do this, because I look after people in care homes quite a lot, it's really surprising how many people have that triple whammy without me knowing. It just happens. And so that triple whammy, of course, is the metformin for diabetes and a diuretic and a non-steroidal. And then you've also got the other cardiovascular medicines such as the ACE inhibitors and the ACEs and ARBs. And so that combination is not good. And I try to do that at least once a year for people who are on more than 5 medications.
Are there any red flags that worry you that they might mention in passing during a consult, which would prompt further concern that the medications might be causing trouble, like, say, dizziness or...
So I've gotten into the habit of asking about falls. People do fall. Remember, a third of people over 65, a half of people over 85. And falls, of course, cause lots of issues. And their medications are implicated in many causes of falls. So I do, are you going any falls in the last little while? And that's a surprising one, and that's a red flag for me. Also, I always ask how are the pills going, and if they seem a bit confused about them or have questions, that's always a red flag as well. Was I thinking the other day about red flags for medicines? I just think that when I was at medical school, John Campbell was a geriatrician, and he accused us as prescribers, and there's not just doctors because there's lots of nurses and pharmacists now prescribing, of when you have an older person who goes off, which means becomes confused, goes to bed. He accused us of causing that, of poisoning them until proven otherwise. So I always think of pills as poisons, and I try to think of them that way, and I'm protecting the older person from the adverse effects of having too many pills or having the wrong pills. Yeah.
So I thought we could dive into some specifics with some cases.
Yep.
So I think that's one of these questions that lots of people are hanging out for and GPs find a bit confusing.
Yeah.
Could you talk us through statins, evidence for their use in both secondary and primary prevention in older people?
Okay, so this is a very common topic of conversation, and I do not think that the answer is completely clear for primary prevention. So primary prevention, of course, is when the cardiovascular risk is getting up, and I'm a great advocate of doing cardiovascular risk. I've been bugging Rod Jackson to actually do the cardiovascular risk equation for people over 75, because, of course, the original under 75 one's all sorted, and he's starting to do that. So cardiovascular risk is important. An 80-year-old who has very low cardiovascular risk, there's still a debate about whether statins are useful for them or not, and there needs to be more trials in fit, healthy older people. When people are very vulnerable or frail or are on a lot of other medications, of course that statins have more side effects than we're aware of from the main reports. I have found that the musculoskeletal complaints, the muscle aches, are more common. And of course, older people, the most important medication you can prescribe them is exercise. And if the muscle aches and pains stop them doing exercise, then that's a really bad thing. So primary prevention, the jury is not yet decided about statins, particularly in older age group. I do want to promote the use of statins because actually the risk profile is lower than, say, for instance, aspirin, because once you get over 80, the bleeding risk of aspirin outweighs the primary prevention risk reduction for cardiovascular disease. But for statins, that is a different equation. So statins are very safe preventive medications, and I don't know why we're reluctant in the well older person. I do think it's very useful to think of older people as being well, robust, not having much wrong with them, even if they've got a few conditions, but they're active, they're resilient, compared with those who are frail and are complex. Those people who are frail and complex, there's much higher likelihood of something bad happening from having a lot of pills. And for those people, potentially cardiovascular risk prevention medications are potentially less important. Again, I'm a great advocate for doing more trials of an intensive way of treating people versus a less intensive, because of course the evidence for cardiovascular risk reduction with triple therapy, treating the 4 pillars, all of those kind of things is very robust. So in the younger, older person, say 65 to 75, there's no excuse for not managing their cardiovascular risk aggressively if that is what they want. Once they're over 85, it's more difficult because of the combinations of medications. And of course, there's 3 or 4 medicines right there. So you need one more to get to polypharmacy. So I do think that cardiovascular risk reduction is one of the best things that is done in primary care. I think it is complicated, and I think we are quite ageist in our attitudes to the very old, and we should be constantly thinking if this is a well, robust older person, you should be offering them full cardiovascular risk reduction.
So you mentioned briefly aspirin. Could you talk us through the evidence there for primary and secondary prevention?
Yeah, so aspirin is interesting because, of course, it's very effective in primary prevention and secondary prevention. Actually, there's one further thing about lipids. Secondary prevention, there's good, strong evidence for people at all ages for the benefits of lipids, of lipid lowering. And so anti-cholesterol medicines for secondary prevention should always be on the table and should always be thought about in the context of whatever else is happening. Okay, so aspirin for secondary prevention is very good, and potentially if for secondary prevention, the benefits outweigh the risks at any age. But you must be aware that bleeding risk increases a lot, and so surveillance and being very aware of that and looking for following the hemoglobin and making sure there isn't any slow leakage. And this has crept up on me in care homes quite a lot. You'll suddenly find that somebody's anemic, and yes, they've been on aspirin for years. It's really the monitoring that goes along with it for secondary prevention, very important. For primary prevention, that balance of risk and benefit changes at about the age of 80. So it's complicated because, of course, primary prevention is one of the things we want to do, but potentially less emphasis on aspirin.
So common medications that GPs worry about, antihypertensives.
Yep. Another great thing to talk about. So the Lilac study, which was, of course, cohort studies of people over 85 and over, 63% of them, both Māori and non-Māori, had significant cardiovascular risk and or had a cardiac event. Over 80% of them were categorised as having hypertension. So high blood pressure is one of the commonest things that are managed for older people. Antihypertensives have changed so much over my prescribing career. It used to be diuretics and beta blockers, and now we start with ACE inhibitors or even an ARB. And so I think managing blood pressure has gotten easier, and those drugs also have other benefits, such as the remodeling of the heart, such as renal protection. All of that, if somebody happens to have diabetes as well, of course, you have to think about that complexity. But managing hypertension, particularly in people who've had a stroke or a heart attack, you must manage it as aggressively as the person can manage. And that means that keeping in touch with them, titrating medications up, and making sure that they're not causing side effects, which will encourage the person to stop their medications. So I'm a great advocate in managing blood pressure until advanced stage. Because, of course, the higher the absolute risk of a stroke or a heart attack, the greater impact of antihypertensive medications. So the better bang for the buck. And now there's also quite a lot of conversations about people who are very frail and unwell, and the Dutch in particular have come through with some evidence that for people who have complicated cardiovascular disease, driving the blood pressure down too low is not good. And there's also the thinking about cognition, that driving the blood pressure too low stops the blood getting through and can impair cognition. And that has to be thought about as well. So it's okay to let the systolic blood pressure run higher for people who are over 75 and over 80, certainly, but I'd still be very careful about the diastolic blood pressure.
Are you a fan of a postural blood pressure check?
Always.
And what are your cutoffs, or when do you get worried that something's dropping too low?
Well, in general, the teaching is if there's a 20 millimeters of mercury drop in the systolic and there's symptoms so a drop in the systolic and a rise in the pulse, that's postural hypotension. If there's symptoms, that's absolutely postural hypotension. And of course, postural hypotension causes falls, and people who have high blood pressure often have postural hypotension as well, and the autonomic nervous system changes with age, and you get that autonomic postural hypotension as well. So sometimes you'll have somebody on fludrocortisone, which is a treatment for their autonomic stuff, and having their blood pressure treated. So it's really, it can be quite complex. But yes, I always, let's take your blood pressure, don't just take it once, but take it sitting and standing, and ask about the symptoms. I was just seeing a neighbour's mother who's 88, and she was having a bit of dizziness and, of course, postural hypotension, hot day, hadn't drunk as much, recently had a cardiac event, not a cardiac event, but been having sepsis and congestive heart failure from sepsis, recovered, but had been diuresed too far. So, always thinking about the course of things and what you can stop rather than start is one of the mantra, I guess.
So there are a lot of older adults who might be considered frail but do benefit quite a lot, say from oxybutynin or anticholinergic medication, sleeping tablets, or things that we get a bit worried about that have psychoactive potential.
Good question.
What is your threshold for when you think, oh, this is just not safe versus, how do you approach that risk-benefit conversation with patients?
Yeah, so the potential for confusion to be a side effect of anticholinergic medication increases a lot with age, and certainly if somebody has an active cognitive problem, so mild cognitive impairment or dementia, the anticholinergics have a much larger effect. And you have to be quite careful about this, because sometimes they've taken their husband's cold remedies, or they've bought something over the counter which has an anticholinergic effect. It's not as common now, but there's always the things that people get over the counter that you have to ask about. So anticholinergics, there is something called the anticholinergic index, which just makes you aware of all of the medicines that can have anticholinergic side effects. And it's quite surprising that you can have somebody on not that many medicines and you find that the anticholinergic index is higher. If you find the drug burden index is high and the person's got cognitive problems, you have to change their medicines before you give them a diagnosis of anything, because it might be direct result of those anticholinergic medications, and stopping them, then of course you have to manage the whatever it was for. Oxybutynin is the hardest one because of course that's incontinence, and incontinence is the big silent epidemic that we have with older women, and it stops them going out and they don't talk about it. So that's falls, how's the waterworks? Those are two questions I always ask. But balancing those risks and benefits of anticholinergics is really important. People know what they want, and they can be active participants in the decision making around what medicines to use and what not to use based on their goals of their lifestyle.
If someone's been on a sleeping tablet for 10 years or so and you inherit them as a patient, or you've started it, no shame in there's some people where that's just been as a management approach. What point would you say, look, I need to take you off this? Or is there an element of just accepting a level of risk if it's giving them sleep?
Well, I think people and their sleeping pills is a complex relationship, and every person who has continuity will understand that. I always try to discuss that with them. It's not I'm taking you off it, it's actually what do you think about this, and the person has to decide they want to try without it. Melatonin is a really good alternative actually, and many people use that to get off their regular psychotropic sleeping pills. And I think the benefits, the big one trial, so John Campbell, who's the famous geriatrician again, he did this great trial where he got people who were over 75 and he got the GPs to select the people who they weren't really needing their psychotropic sleeping tablet. And so that's, of course, the PAMs, the diazepam-related medications. And so he got them, enrolled them in the trial, looked at their falls as they went through, and then had the same coloured pills, and in one randomised coloured pill, there was a gradual reduction of their sleeping pills to 0, and the other coloured pill was their usual dose. And so over the course of a year, of course, half of these people ended up having none. It was interesting that both arms of the trial had the same frequencies of complaining of sleeplessness, of complaining of anxiousness, of complaining about trouble sleeping. And by the end of the trial, the intervention group, who now were not taking their sleeping tablets, their falls fell to 20% of the control group. So very, very effective in reducing falls. And yet at the end of the trial, when everybody was unblinded, within 6 months, more than half of those in the intervention group who were now knew that they were not on sleeping pills and that their falls had been reduced, went back and got their pills from their doctors. Their doctors gave them to them. People are very persuasive. I understand that. But that's a real lesson to me, is that it's a very effective method of preventing falls, but it's very hard for people to engage in it. So we all have to develop lots of different tricks and, use the wonderful therapeutic relationship that prescribers have with their patients to gently and gradually encourage them to cease and desist taking their sleeping pills. And of course, the history of sleep is fascinating, because in the olden days, before we all had to sleep all night, actually people all slept in the kitchen. Of course, there was multiple wakings during the night to stoke the fire, to do this and that. And then as we got bedrooms, we got this idea that we had to sleep all night. Sleeping all night is not necessarily a natural occurrence looking back, centuries. But we seem to have become wedded to it. So I try to get people to accept that maybe it's okay not to sleep all night. I do try to get them to not nap during the day, lots of exercise, particularly exercise outside in the light of the morning, because that makes their pineal gland wake up and work and produce their own melatonin. And then more and more lately, I've been using melatonin for sleep rather than anything else. I'm also very worried about quetiapine. Somehow, for particularly young people, we've started using quetiapine for sleep. Quetiapine is a major tranquilizer. And if you're using it for a psychiatric cause, okay, but why are we suddenly adopting quetiapine for sleep? I think we really have to think about that, because quetiapine gives people metabolic syndrome, even in low doses. So I want to have a quetiapine-free clinic along with my augmentin-free clinic. I want to raise the profile of quetiapine as being a no-go drug.
That's a good point. So it brings us to just having a conversation with our patients about deprescribing. Could you talk us through your sort of strategies that you found useful or an approach that you'd recommend?
Yep. So I don't like the word deprescribing because it's appropriate prescribing that we all want. Some people will need their 7 medications if they need good cardiovascular risk reduction, if they need appropriate diabetes management, if they also have GORD, which has been causing them trouble. They may need all of those medications, so that is appropriate. And sometimes you have to add, particularly a bisphosphonate, for bone protection in somebody who is very high risk or has just had a fracture. So it's not deprescribing so much as appropriate prescribing. I think there's different groups of people, and somebody who's relatively robust and well, go for guidelines-driven medication use and cardiovascular risk management and offering everything. For somebody who's frail and is at high risk of side effects from medications, or who has particularly bad renal function, you have to be really careful. And reducing medication dose as well as reducing medications is a really, really time-consuming and useful thing to think about doing. And I also try to simplify the medication regime, because taking several pills a day is problematic. If you can get them to the 1 tablet a day on that class of medications, do it. So beta blockers are a good example. Now there's some very good options for one tablet a day for beta blockers. I also think that you've got to keep up with the changes in medication that are coming through. How you do that, I don't know. Podcasts are a very good way. I love the podcasts from the Goodfellow unit. But things have changed, and the big revolution in the last 10 years has been the new diabetes drugs and the new cardiovascular drugs. So you've got to keep up with an empagliflozin and dulaglutide and all of those things. And now we have Wegovy on the map. And of course, that's a younger age group and potentially a long-term medication, but you've got to understand that and all of the side effects that brings upon you. So deprescribing, don't like the word. Appropriate prescribing, like the word. Yes, reduction in medications is a goal, but actually having the most appropriate combination is actually the goal.
And for our Māori or Pacific populations, who get sicker earlier with more things going on, what would be your advice regarding maintaining an equitable approach to medication management in this group?
Reduce the barriers to access for primary care for people with no money. So it's a huge disadvantage having to pay to go to the doctor when you have no money and you're trying to keep food on your table. Māori and Pacific people are just as interested in their health, if not more so. It's about the relationship with the person and reducing the power imbalance and reducing their barriers to access. And, there's like the polypill trial where they put all of the cardiovascular medicines in one pill was very successful in reducing cardiovascular risk, particularly for Māori and Pacific people. So we need to be thinking proactively. We need to be reaching out. We need to develop a new way to do primary care which is acceptable for Māori and Pacific people, and we need to reduce all the other things in their lives, all those structural barriers with socioeconomic deprivation that prevent them from being able to think about their health very well. There's a very good story that I was privileged to hear about a very older Samoan man who's had diabetes very badly and was not interested in taking his medications. And so the GP sat there and talked with him and his family and discovered that he was actually translating the Bible into Samoan. And that was his goal in life. And what an important contribution that was going to be. So they talked about how that was going to take some years and that it was really necessary for him to be well and to be able to see and to be able to think clearly. And the pills for his diabetes were just a helper for him to get to that goal. And his whole attitude to the medication has changed then. So it's about knowing the person. It's about knowing their aspirations in life and how you as a clinician, as a practitioner, can help them reach their goals.
So do you have any recommended resources that you go to or consult? I'm sure you'll talk about them a lot more in your course, but that you'd recommend for us? And we can
We do.
them?
We have some pretty good resources in the course, but I always go to the New Zealand formulary. They've got this great thing which lists all the interactions. So you've got a function there where you can see the interactions that perhaps you hadn't thought about. So the New Zealand formulary is very good. I also do look through the resources in BPAC and on the Goodfellow unit. They're very good and up to date. I think that's very useful. I don't have any other magic resources except to ask people to think about it and to keep looking. I always, when I prescribe something new, I actually open the MIMS thing and I read it, because older people, new things come up. Actually, I find that the hardest group to manage are the middle-aged people who have complicated medication regimes and complicated lives. So I find older people are easier. They generally can sit down and have a conversation and you can get to know them. So I think do the course. If you can manage to do that, I think it's a really useful course. It's a university 30-point postgraduate course. And so, yes, it takes, half a year. It's quite busy, but there's a lot of learning in it. There's 6 modules. They go over psychotropic medications, cardiovascular medications, diabetes medications, and then the combinations of things, and thinking about the risks and benefits of weighing up the complicated stuff. And Dave Woods, who's a fantastic clinical pharmacist, is the co-convener with me, and Gigi Lim, who's a nurse prescriber, she also is there with us. It's a challenging area. I think it's worth it. Your peer groups should always be talking about medications, and the college also is accruing a whole bunch of things for people to be useful.
What are your key take-home messages for our listeners?
Ask about the pills. Ask about falls and incontinence. Encourage people to understand their own pills and become their own. I do think it's okay for them to hold their frusemide for a day when it's very hot, and I think as long as they understand what's going on, and really do sit down and go through the whole list of them at least once a year and think about what can be tapered to off and think about what's not there that could be there.
Thank you so much for being here, Ngaire. If you're a New Zealand GP and would like to claim CPD points for listening to this episode, our podcast is eligible, so please log them. You'll find links to the relevant resources that we've discussed in this episode today on our website at goodfellowunit.org. And if you'd like to get in touch, we value your feedback, so you can email podcast@goodfellowunit.org. Thank you for listening.